stealing it from Core, but yeah, in spirit, it's my logo. We'll just wait another minute or so. Has everyone found their way at St. Paul's yet?
Yeah, we can hear you. You're a little bit faint, but we can hear you. Yes, you can.
Okay. Okay. Oh, did I do something? Okay, well, maybe if people have found their way, maybe we'll get started then. So I'm happy to be here today to talk about a topic that's of interest to me and many in the room, and part of what we do within nephrology and the renal agency. So I think this was important for me to talk about just as sort of an introduction that sort of mirrors my interest in quality improvement and within hemodialysis and nephrology. So I recognize that many of you in this room have actually spent quite a bit of time already working on quality indicators, but others may have not heard much about them so far. So why I thought this was an important topic to think about is that in nephrology, we all know that we have lots of numbers, and we're easily able to measure things. And that makes it a really good area to look at quality improvement, and that's probably why I went into nephrology and why I went into quality improvement, is that they mirror very well. But I also have really realized that when we do this measurement, it can drive improvement, but can also have unintended consequences if we choose the wrong things to measure, and increasingly aware of how much what we measure really drives our attention when it comes to our day-to-day care. So in BC, as many of you are aware, we do have a strong quality indicator development history, and we have an enviable data infrastructure compared to many places across the country. This topic, I think, is pretty timely, as many national, provincial, and local initiatives are re-looking at quality indicators and how they relate to quality initiatives. And we're just about to get way more data. So with EHR, CST, all the initials of the different programs across the province and country, we're about to get even more data than we already have in promise about things like our performance and our metrics for our patients. And I think this gets down to the bottom line that basically there's a recognized need amongst many of us, or all of us, that we may need to reevaluate how we really measure quality and focus on metrics that are linked to important outcomes for patients and ensuring that they're linked to evidence as well. So I don't have any disclosures, but what we're going to talk about today is really aimed at generating some discussion. It's not the magic pill for these are the indicators that we should be measuring. This is really about thinking about how do we define quality and quality indicators, what indicators are we currently using in BC, looking at a framework that we could use when we're looking at developing and evaluating both new and existing quality indicators, and looking at some of the provincial and national work that's currently being done in the area of indicator development. And per my personal bias, we're going to focus a bit on hemodialysis. And we'll look to conclude with describing some current gaps and barriers in developing and implementing meaningful quality indicators. So quality is a term that gets discussed a lot. So it's a little bit difficult to define, though. So how can we define what quality means in healthcare and within nephrology? It's kind of one of those things, you know it when you see it, but you also know it when you don't. So I think it's one of these things that's a little bit abstract and difficult to define and difficult to think about how it affects and drives much of what we do. But the kind of traditional definitions that we think about include the fact that it is hard to measure. And within healthcare, it means providing care for the health of individuals and populations, which improve their outcomes using the best evidence available. And it really does move beyond our best or good intentions. So a lot of times when we think about quality, we think we're doing a good job, we want to do a good job. We're thinking about improving things for patients, and we come up with initiatives that may do that. But I think it's important to reflect when we go through the talk about the fact that we won't really know if we're making an improvement unless we have some measures of this quality, recognizing that it is difficult to do so. And I think quality does also mean reducing variability in practice when it's possible. And there's, as I mentioned, many definitions, and the WHO points out that this care should be safe and effective and timely, efficient, equitable, and people-centered. And I think none of us would disagree that those things are important, but they're a lot more difficult to put into action. I think just thinking about what quality of renal care may not be, sometimes it's maybe easier to think about a patient that we had that had a journey that kind of fell short of those quality aspects. So if we think about, say, an elderly lady that's referred late to the kidney clinic, she goes to her first appointment, she mentions maybe she doesn't want dialysis. She has an appointment down the road in a few months to talk about it more, but ends up in the emergency room. She starts dialysis with a temporary line because she feels like she can't make a decision. She didn't have enough information. And she stays in hospital for several weeks, and she gets infections, and she declines from a functional standpoint. And when she makes it home, she comes back quickly because she gets another line infection, or she gets volume overloaded because her goal weight wasn't reassessed, or she has a medication adverse event. And those kind of things are things that we strive not to see, but that we see all the time. And when we think about what quality might be, I think we can all agree that these kind of abstract concepts like staying out of hospital, having good access to transplant, not having adverse events occur for our patients, having things like language services, having things like timely evidence-based care are really important. But again, it's still in that bubble of really what does this mean when it comes down to measuring things. So quality indicators, in terms of what they are and what makes a good one, I think we all know and have heard the term and quote that what gets measured gets done. And I think what's important about this is not just what gets measured gets done, but also gets our attention. So just kind of reflecting on my week. So I was in the blood work week for hemodialysis. So I spent a lot of my week increasing calcium, decreasing calcium, increasing medications, this and that and the other, and kind of struck me that I lost a lot of time with patients and didn't actually have a chance to interact with them in some of the ways that are actually probably meaningful to them. And I'm not sure whether those things are important to them because we don't really know. Which is to say that there's really no direct measures of quality, but we have to do the things that are measurable if we want to look at improvement. So there's lots of names for quality indicators: performance metrics, key performance indicators, quality metrics. But basically, to be a quality indicator, you should have a clear definition of what your scope is and have a numerator and a denominator. It actually has been shown in many studies that if done well, using quality indicators in relation to your objectives for improvement can improve quality of care. Now, we have good examples of where that's fallen short in the US, where the intentions and the use of the quality indicators may have led to unintended consequences, but there is evidence that if you do it right, it can be helpful. And we have another quote that every system is perfectly designed to get the results it gets. So when we're thinking about quality improvement, we often think of a family of measures, like we have process measures and balance measures, and we have outcome measures. But when we think about quality indicators, sometimes it's helpful to separate them in a different way And this can be a good way to make sure that we have all of these things checked off when we're thinking about developing new quality indicators. So the first is structure indicators. These are things that reflect the ability of our system to basically deal with patients. So these are really the resource implications. These are super important. If we don't have the capacity, we can't care for patients. It's kind of like the bottom line must-haves for a system. And this even relates to things like water quality. Like, we must have water that is safe in dialysis, otherwise, full stop, dialysis is not safe. But these are things that are inherent to our administrative data. Process indicators are more about measuring the care that's being delivered. This is really the focus of most of the existing provincial indicators. It's looking at things like wait times, what are our vaccine rates, what are our modality selection in the kidney clinics, and this really relates to the way that we do our work on a day-to-day basis. The outcome indicators are really looking at the health status of patients. So this includes things like adverse events. We have some of these in our current system, like bacteremia, patient satisfaction is one that we'll talk about later, and survival rates on dialysis. And if we do these outcome indicators right, we may get to what really matters most to patients. In terms of what we could use the quality indicators for, one of the things that's key is using it for quality improvement. Sometimes comparative reporting or accountability may be the way that we're using it. So, for example, with that water indicator, we just need to have safe water, so we need to be flagged if it's not safe. But on a day-to-day basis, we're not really working on quality improvement for water. Performance incentives is something that's really used mostly in the United States. So when we're thinking about funding or pay for performance, we're looking at the carrot versus the stick kind of approach. So both in the United States, they have held back funding if you don't meet a certain indicator, but they also have used indicators in different ways. And if you are in the States, you can Google your dialysis unit and find out what its ratings are. So they have kind of like a Rate My MD for dialysis units. You can look at like what the patient satisfaction is. You can look at things like infection rates and all that. And there's some interesting data that kind of comes out of that, but I think that's not really the direction we're going. So here in the province, we have our data infrastructure and indicator reporting already. And as you all know, we report on a lot of quality indicators, and most of them are structural or process, but we have some outcome measures. And I've just listed some of the reports that many of you are familiar with here in the province. One of the main indicator reports is our management indicator report. And these are really 12 key indicators that have been prioritized in the province to be something that we focus on together to improve. And there's benchmarks, as you can see on the previous slide, that exist about how well we're doing. It's interesting to reflect on these. The two things that kind of come to mind when I'm looking at them is one from my perspective. There's not a lot of things that directly to hemodialysis care, except for the two that I've highlighted, which are also the two that are the outcome measures of the bunch. So most of them are really looking at the processes of what we do, and that's super important because we need to improve our processes and transitions in care. But we only have a couple that are really true outcome measures. And there's a need, and we'll talk about this later, in the province to think about what we want to focus on in hemodialysis. Because these things are really challenging to do. And one of the problems that you get to, if you start looking through what are the possible indicators, you're going to end up with too many indicators, because I've already said we have more data than ever. And so it's easy to fall into a trap of like, we can measure everything, let's just tell you everything that we've measured. But that's not really a powerful or impactful way to lead to change. We also have limitations in our evidence As we know, we don't have a lot of randomized control trials about what we should be doing in many cases, so it makes it harder for us to choose something that's more powerful. And sometimes data limitations exist, and there's some logistical issues. There's some issues with timeliness and accuracy. And one of the main sort of criticisms of indicators is, what do you do with them? So when you're putting out a report, what is the purpose of the report? What are you trying to achieve? Are you trying to do that carrot and the stick, or are we just trying to compare ourselves to others or set a minimum standard? But one of the other concerns that most people have with indicators is the gameability. So here's an example. Say we have a new indicator that we should look at the percentage of incident dialysis patients that have advanced care planning discussions within the first 90 days of their dialysis start. That sounds like a great thing. Like we want advanced care planning conversations for our patients, and we want them to happen early. But I could just go around the dialysis unit and say, advanced care planning to patients is important, and just say, hey, we should talk about advanced care planning, and then move on, tick box. Hey, let's think about your code status, tick box. So, I mean, there's a real difference, and I think that's intuitive, that there's a difference between a meaningful conversation about advanced care planning and a token conversation to meet an indicator. And that's the kind of thing that we've seen a lot in the States. So, you know, the KT over V target has led to the shortest dialysis times in the world in the United States. And another example is their recent adoption of a UF rate indicator, where they basically say you can't have more fluid removal per hour than X, which is 13 mils per kilogram per hour. Sounds like something that might be important, but if you just say no one can have more than 13 mils per kilogram per hour off, then you meet 100% of your target. But what are you doing about changing the root causes of that, and what's happening to the patients that may end up in the emergency room with volume overload because you didn't actually address the root causes? So this gameability can be combated a bit with complementary measures, and also clearly defining what you're actually using as your indicator. One of the other challenges is comparison difficulties. So this is really important for buy-in. So if people don't feel like the data from other centers or their center is being collected in an accurate or transparent way, they're just not going to believe it. So if you say, I'm not doing as well as advanced care planning as so-and-so or other center, there may be a temptation, if it's not clear how the data was collected, to say that the data is wrong, or that there must be a problem with the data. And we come up with that sometimes for good reasons, but there's a lot of things that need to be considered. Another challenge is that population metrics or indicators may feel to clinicians that they're losing their ability to individualize care. And I think it's important to emphasize that really it's not about reducing all variation, it's about reducing unintended variation. We'll talk more about later about the lack of patient-reported outcome data. And then I think one of the key things that we deal with here when we're thinking about provincially is, yes, we all work in different areas within renal, but if we're focusing on trying to, say, make an indicator in hemodialysis or vascular access, we need to think about how the reasons for those issues may cross over clinical areas. So who is actually responsible for improvement, and is it even modifiable under our locus of control? So example would be incident fistula rate. So whose metric is it? If we're working as provincial groups, obviously we're all really working together, but is it a kidney clinic measure? Is it a vascular surgery or hospital wait times measure? Does it relate to hemodialysis? And there's lots of examples of that, and I think it's important to kind of define what aspects of care we can really modify or not. So with that in mind, just thinking about how we can have a clear framework to develop and evaluate indicators. So approach that I'm proposing starts with basically, and this is what we've done in the national initiative, which I'll talk about later, is just do an environmental scan, see what's out there, look at research, and see what could be helpful as an indicator to identify both existing and novel quality indicators. Then you should make some kind of a working group or panel where you're going to look at the existing and novel indicators and evaluate them. And you must evaluate them against some kind of rigorous criteria and have a selection process for choosing the metrics. And we'll talk about this in more detail. It's really important that at this phase, there's clear definitions and measurement strategies for the selected indicator. So you need to have a strategy for feasibility. You need to have a strategy for comparability. And that may be less or more complicated depending on the indicator. And then you need to think about what are your benchmarks, and these may change over time, of course, and what are your intended use of the indicator. So this is thinking about things like your reporting strategies. How will you do knowledge translation if it's needed in the area? And then reassessment, I think, is really important. So we need to look at some indicators and think maybe we need to retire some of the indicators. If we need new indicators, where are the barriers to getting the data that we need to look at those things? So when we're starting with the environmental scan, and I'm not sure how well this projects, it's important to think about the different categories. So one way to think about the different categories is thinking about the structure, the process, and the outcome measures. But this paper in CJSON really, I thought, summarized well what the different types of things that we might want to be using, because we want to have a complementary group of measures. So at the top of the pyramid, we have what matters most. So that's thinking about the quality of life of our patients. We have measures of effectiveness, so mortality, hospitalization, patient experience. And then we have all the complex programs that might exist within renal care. So things like how are we managing fluid? How are we doing with education? How are we looking for infection control issues? And then the fundamentals on the bottom are the things that we all know about our patients. So are they getting immunizations? Do they have very high PTHs? Do they have phosphate? And those are the kind of things that we've been measuring as sort of fundamental metrics of at least meeting base targets, but maybe are not the things that are the most important for us and for patients. So when we think about how we're evaluating a potential metric, I think we can all agree that it should be something that's important, something that is useful and for a purpose. It should be scientifically sound, so it should have a basis in evidence. So if it doesn't, then it's difficult to know how it's going to change the outcomes of our patients. It ideally should be feasible, although we have to think about the fact that there may be some things we want to look at that are currently not feasible but could be feasible in the future. And they're usable. So we need something that the target audience can understand easily, can interpret, and can use for improvement. So in terms of what's important, I think we all understand what's important is something that would have a large impact on a desirable outcome. But one of the things that falls within importance is we really need to know, is there really a performance gap? And sometimes we don't even have the data to know if a performance gap exists. But in a performance gap, we have variable care, substandard care. And this is distinct from looking at gaps in documentation. So just because maybe we are having advanced care planning discussions with every single patient, we don't have a performance gap just because we're not writing it down necessarily. So we're looking for things that we're really not doing. So in that vein, it's important to know when a given indicator is no longer contributing to quality because it's topped out. We're already doing 90%, 95% all the time, every program. It may not be helpful. In terms of being scientifically sound, this basically means that improving this indicator will improve health. And when you don't have a direct measure available, you may need to use surrogates. But the idea is that you require robust evaluation and research into the clinical endpoints where available. And you should choose benchmarks based on that too. So the benchmark should also have at least a vein in evidence or consensus. And sometimes the validity of whether it's scientifically sound metric or not may be different based on the population. So maybe you haven't studied it in every population. Maybe fistula outcomes are less important in the elderly than the overall population. So one example would be our phosphate, so reported in our core reports. Really hasn't changed in, I only have 10 years back or something, but really if you look at the mean phosphate, it hasn't changed in 10 years. And we only really have weak evidence to support a link to lowering phosphate in important endpoints. So this is one of the things that we have to consider, whether it's truly important and whether it's truly a measure that's scientifically sound. In terms of feasibility, it's basically, can it be implemented? Can we collect the data, ideally without additional effort, and including that it's precisely defined and specified? We need something that's reliable in measurement and reporting, and something that can be compared against across centers. In terms of usability, this relates to the extent to which programs will use this reporting for improvement, as I mentioned before. And it means that the results have to be accessible and easily interpreted, and that there needs to be some kind of rationale about how you would make improvement within your own program by looking at this metric. So some kind of physiologic or theory base. I think one of the key things that's really important if we're looking at them for quality improvement is timely data reporting. So if we want to make ongoing changes, it really needs to be reported, and ideally quarterly. So some of the things that have been looked at that are more difficult to measure, we only can manage to measure every 2 years, every 3 years. And that doesn't really help us change our day-to-day practice. And we've talked about that already. So when it comes to those kind of 4 criteria, looking at how we can put it together, what we used in our national project was looking at this set of criteria and coming up with consensus about whether we agree kind of as a group that it is important, that there's evidence, that there's a performance gap, that we can precisely define it, that we can risk adjust, meaning compare between different groups, and whether it's feasible and whether it's usable. And basically based on this, come up with sort of a rating scale to help us decide what indicators may be helpful or meaningful for us moving forward. So when we think about some of the indicators used in nephrology generally, and I'm not just saying BC, I just mean generally, so we have some of the common ones listed here. So if we think about whether they're important, scientifically sound, feasible, usable, many of these are important. Some of them maybe not so. Some of them are more scientifically sound or based in evidence than others, and some of them are more feasible than others. All of these here are feasible, I would say, and some of them are more usable than others. But I think something that I have alluded to but haven't touched on yet is whether these indicators, which we commonly measure across Canada, are actually patient-centered. So of the ones that are listed here, how many of these are things that the patients care about? And how many of these things are the things that we most care about? So that brings me to the reason why this is being worked on both nationally and provincially, and there's lots of local work that everyone, you know, in the audience is working on as well to try to improve the patient-centeredness and the evidence base. But what I've been working on for the last year in the Canadian Nephrology Quality Improvement Collaborative, which was formed last year, initially to partner on national quality improvement projects. But what we've been working on more lately is to collaborate and build consensus on quality indicator development and evaluation. So we've formed 4 working groups. I am part of the Hemodialysis working group. Chris Poignan has joined the Home Therapies working group. So that's great. And there's a recent partnership with CSN. And this work was initiated by Sam Silver. So what we have done as a group is last year and into the winter of this year, looked at this environmental scan of local, provincial, and national quality indicators, basically by just reaching out to programs across the country, finding out what are you measuring, and that doesn't have to be your official provincial report. That could be something you're working on within your hospital. The second step, which is what we're finishing now, is evaluating the metrics in working groups using the criteria that I mentioned to build consensus with an aim to essentially make a balanced scorecard for each renal area with suggested indicators and publish those results. So I thought it would be useful. I think it's a lot to talk about every single indicator that we have been looking at within hemodialysis working group, but thinking about themes and some of the metrics that we talked about that we're already measuring. Some of the things that have been looked at provincially and locally include a more emphasis on advanced care planning, patient-reported outcome measures, so things like symptom scores or quality of life, patient satisfaction of care, resource utilization, so hospitalizations, emergency visits, access to care. Some of the structure measures, in addition to what we're already reporting, include things like no-show rates, capacity, which we already measure, and travel time, which gets at accessibility, as we know that Canada is a very geographically diverse country. And infection control metrics, like things like hand hygiene and catheter care. Some centers, like for example St. Mike's in Toronto, is putting a lot of emphasis on metrics that focus on volume management. As I think we all realize within hemodialysis that KT on V is not just adequate care in and of itself. So adequacy, thinking more broadly in terms of volume management, hypertension and hypotension control, so things like UF rates, weight gains, assessment of dry weights with technology like ultrasound or bioimpedance, and transitions in care, which is super important. And then getting to the bottom, those are things that we're commonly measuring here, so vascular access metrics, which are still very important, patient survival, which we can all agree is important, and the traditional lab-based metrics like adequacy of KT on V, anemia, CKD, bone mineral metabolism. So what we have found, and so those are the types of themes, I'm not getting into the exact detail of the ones that we're currently evaluating, but the barriers and gaps that have really come out across Canada have been data limitations and feasibility. So we are really lucky here. Many of the provinces are really not reporting many metrics at all. They're just doing the core data. So just what core is putting out, that the provincial report that we get or the local reports, that's what they're doing, because they just don't have the infrastructure, apart from Ontario, to really report out any of the indicators that I just mentioned. So any of those things that they're doing, they're just local initiatives where they're just getting down and doing primary data collection themselves. So that brings me to what if you don't have the data? So there's sort of two broad approaches to indicator development. One is inductive, so that's you have the data and then you decide what to measure. So that's what we've traditionally done, so your phosphate, your clearances, and then there's deductive. So what do we want to measure? What do we think is most important? And then how can we make that work as a metric for us? So this is an opportunity when we think about doing the environmental scan and seeing what's out there in the research, both locally, provincially, and abroad, to think about how we can work with our existing data stewardship to improve our ability to measure things we want to measure. But there are easy ways to do this even without changing the whole system. So you could say we're already entering ESAS or acuity scale at certain variation. What if we just put in intradialytic weight gains or the UF rate on that day? So there are ways to kind of bridge gaps in terms of piggybacking, or even just focusing on a small group of people, doing a random sample of people that you want to collect data that's a little bit harder to collect. The second barrier has been, and I'm sure will remain, the lack of strong evidence to support some of the novel indicators. And this really gets to reliance on, some cases, on expert opinion and consensus building, which we're familiar with in nephrology. because we don't always have the randomized control trials, but I don't think we need them if we have a good basis in terms of our intent and a theory. But I think the most important thing, and I think the thing that I'd want you to take home, is that the major indicator gap across Canada is that quality of renal care from the patient's perspective is not being captured. And so we have to think about what quality means to patients. So within hemodialysis, there's some research and surveys that have been done or continue to be done to look at what's the most important aspect of care to patients. So there has been the Patient Assessment of Chronic Illness Care Survey done, I think 2009, and then every few years since then. That was done in all renal areas, but looked at a need to be felt, to be met, in advanced care planning, goal setting, and patient involvement in their treatment, and that's prompted some ongoing work that Helen Chu is doing in patient engagement in BC. But one interesting study that we actually were part of here as a phase 2 survey is the Triple I study, which is led out of Manitoba by Clara Baum. And basically this is to look at, from the patient's perspective, what are the challenges and potential solutions that they see within their hemodialysis care. And so I think the results of this study, which hopefully we'll get soon, will really help to guide a lot of the direction, especially within hemodialysis, on what we can look at as important to patients. And so as a provincial hemodialysis committee, led by John and Janet, embarking on looking at evaluating and developing quality indicators within the scope of hemodialysis. So this is recognizing that, one, we're not finding a lot of indicators that are important at measuring hemodialysis quality, but two, the ones that we can easily measure may not be the ones that we want to actually look at. So we want to focus on metrics that are linked to important outcomes for patients and led by best available evidence, and build upon the national work that is sort of wrapping up that I mentioned with a provincial perspective in terms of our feasibility. And this will hopefully provide guidance to local programs in a meaningful way. And so this was discussed at the face-to-face meeting last week, and a working group met this week for the first time. So in conclusion, I think what gets measured gets done is an important thing to continue to repeat. And I would add again that what gets measured and reported is how we spend our time and how we reflect to patients what we think is important. And when there's that misalignment, that may lead to problems with patient satisfaction. So we need to be thoughtful in terms of choosing things that align well, as this will drive our attention and time. I think we also have an external factor that I've kind of alluded to, which is CST. So if we think about electronic health records coming not just here in the regional setting, but across the province, we have to be aware that some of the data will fall out of our control. So we're going to have potential for the Ministry of Health to give us indicators like what's happened in the States. And so I think it is important to get ahead of it. So can we think about what indicators are important, or are they going to say your patients get admitted too much, your patients use too many resources, your patients are dying, they're having catheter infections? We should know that data well and think about how we can improve it before we get the carrot and the stick approach coming our way. So furthermore, when feasibility is limited, we may need to look at our existing data infrastructure. And I think to get buy-in from people, because I mentioned a lot of the criticism, is we need to use a group of measures or a family of measures that include balanced measures that limit the gameability and the unintended consequences of using indicators. Because I think it's easy to put out a report or to set a certain standard, but it really has to be meaningful. One of the unanswered questions that remains is, again, just thinking about the patient. So what are the best measures of quality in nephrology from a patient's perspective? And thankfully, there's already a lot of work being done in this area, but it's not going to be easy to actually do this on an ongoing basis. So this was a cartoon that I found from the NHS when they were looking at quality and measurement. So we have a guy who's got a measuring, he's measuring what he thinks is important, and the patients are all thinking different things. So I think this is kind of like the blood work rounds. I'm going around, I'm measuring the phosphate, and they're thinking, can I go to Hawaii? So I'm happy to take any questions. It really was just meant to prompt some discussion in this area, given the fact that I think everyone is working on this already. I hope that you can at least reflect on the criteria that we've discussed today when choosing new metrics. That's it. Any questions from St. Paul's or elsewhere? Any questions at all?
Here, Claire. Claire?
Yep.
So, hi. So thank you. It's really great to sort of get an overview like you've described. And I think the example of vascular access is a good one because maybe it doesn't who owns it, but rather that everybody owns it, so it's everyone's problem to fix. And I think that as I think everyone here knows is that despite lots of great efforts, it's been very difficult to change the vascular access rate for incident or prevalent patients. And it's not just an OR problem, although that's what people say. So is there some appetite to sort of do a more systems approach to how, what all the different issues are so that we can map it out so we don't just come up with a solution, which seems to be just pay people to do more vascular access. And if we do a pay for performance, it'll all get better. But I think you would agree that's probably not the right way to do it.
Yeah, I think that we all need to think about what's in our scope, but I think having a bigger picture is a really important point when we're thinking about that Venn diagram of, say, vascular access. We're thinking about perhaps mapping out using quality improvement type tools to think about the steps in the process, the bottlenecks in the process, and who can help with each aspect of that. So I think it does require collaboration amongst the provincial and local committees to try to find, meaningful ways to look at one thing, because we all know if we just pay more vascular access surgeons, that there'll be a bottleneck that'll pop out somewhere else. And so I think that is a really good point, Azira, and something that we need to do, especially for important things. But I think the thing that I would add would be looking at, is there a better way to look at the metric for patients that we think are best suited for the vascular access, and perhaps reframing the ideal access for patients. So the ideal dialysis access may be different for different patients. And so maybe some added layers of context might be also helpful, but I agree. I think there is probably an appetite to do that.
Thanks, Claire. That was a good talk. Question, there's always that tension that comes up when we look at sort of the patient desires versus what we feel is important. And obviously there's sometimes if you look at the list of things that are important to patients versus the list of things that are important to the healthcare providers, they're often completely inverted from one another. And that's not to say it's not important to be doing that, but how do you, I always struggle how you find that balance of meeting the needs or the desires of the patients, but then having to also understand the things that are medically important, and how do you actually strike the balance for that? Because that's a huge thing with hemo. I mean, your example is good. I mean, I think we spend an enormous amount of relatively futile time changing blood work parameters when we should be talking about going to Hawaii. But how do you actually balance those very divergent opinions?
Yeah, it's a really good point. I think when we think about indicators that we think are important, or the medically indicated indicators, and we think about the ones that are really important, really based in evidence, really critical to how our patients do, then we probably need to do a better job, and this is obviously really difficult, at trying to educate patients about how it's important to them, but also accepting that in some cases patients may still not want to do what we think is important. And that may be okay as long as we feel we've done a good enough job at it. When we think about and learn about what the list of things that's important to patients, I think it does require a lot of qualitative type research to think about why is that the thing that's important to them. Like, what are their perceptions that they got to that led them to be most concerned about their coming at 7:30 versus coming at 12:30. Well, there may be really important factors to patients' life that we're not appreciating. And it may be that we just didn't tell them that they could go to Hawaii. It may be that we didn't provide the education that they needed, but I think if we better understood that their list, we could help educate and prompt those things up front. And if we narrowed down our focus to the things that are really, truly important and didn't get this big clutter of things that are kind of important or not important, it would be less confusing for patients, I think. Because right now they're getting this report card, for example, with all these blood values, and they're getting kind of perhaps mixed messages about what's really the most important thing in their care. So if we kind of said, actually the most important thing is, say in dialysis, is your volume management and keeping you out of hospital, and we are showing you by our actions that those are the most important things because that's what we're spending our time doing, I think they would think differently. I think it's confusing when all they hear is from a nurse saying you're heavy, you've gained too much weight, but then we're going around and we're talking to them about totally different things and not showing with our actions what's actually important. I don't know if that answers your question. Chris?
Thanks for the talk. That was a great overview. Just drawing upon the home therapies, when we had our group discussions with the quality indicators and trying to put the criteria, we generally had a fairly good consensus across the board. Mm-hmm. Just wondering, in the hemodialysis world, you mentioned some centers are more volume-based versus, versus criteria. Have you found consensus for the most part, or has there been good debates?
There's been a lot of consensus about which metrics are important and which metrics are evidence-based, but there's been less consensus about which metrics are feasible and usable, because that's really center-specific, and that's why I think, although it is great to say nationally what we think would be our ask, really it needs to be in the context of your own center about what you can actually do. So we are actually very lucky. I'm sure you realize the same thing, Chris, that many places just don't have the ability to look at these things, and therefore they don't have the ability to use them.
Hey Claire, it's Gary. Just a comment and almost a question, because you've mentioned, I guess we're really lucky here with the information we have in Promise and the stuff that we are collecting, and really it's a plug to the province and to the people here working in this era of change and with CST, etc. Really just to remind people to keep in mind as you're going through, and I know the Interior is going to be going through some change with their system and Fraser in the future, that to be aware that you need an integration team or someone to be working with these groups, such as we are with Cerner. I know Mike and Monica are spending an enormous amount of time with them, but to make sure, number one, that we don't lose the data that we have, and that we take all the opportunities to enhance the data that we are receiving from these systems.
That's a great point, Gary. I think, at least from my experience working on the hemodialysis working group within Cerner, there's some really great potential advantages that if we push for them and we get what we're asking for, we could actually get some of these metrics that I'm measuring just by virtue of the way things are going to be captured. But we have to be careful not to lose the existing data infrastructure. Yeah. Okay, well, I think that's it. Thanks, everyone. How do you move? Is this?